I would like to introduce our fourth and last speaker, last but not least, Dr. Hamed Ektiari. Dr. Ektiari is Lab Director of the Neuroscience-Informed Interventions for Addiction Medicine Center for Neural Circuits in Addiction, Neuroscience Department at the University of Minnesota. He is also adjunct faculty at the Laureate Institute for Brain Research. His research focuses primarily on using neuroimaging and neurocognitive markers among people with substance use disorders to inform the development, predict outcome, and monitor efficacy of non-invasive transcranial electrical and magnetic stimulation, as well as neurocognitive interventions. His talk today is titled Multi-Level Brain Mapping to Optimize Neuromodulation in Individual and Group Levels in Substance Use Disorder. This will cover his work developing novel tACS methods that consider inter- and intra-individual variability that could ultimately form the basis for precision medicine in brain stimulation for SUDs. Please welcome Dr. Ektiari.
Hello, everyone. I'm really excited to be here, and that's the good news that I'm the last speaker of the day, so after my talk, you will be free to enjoy the reception and poster session, so everything would be almost done. And I put all my slides in the QR code, so if you just scan the QR code, you can have all my slides, and we'll provide my the QR code at the end as well. So if you're interested to have the slides, feel free to just download all the slides that I have in the presentation. So I do not have any conflict of interest, but before starting my talk, I would like to thank all the mentors and colleagues and collaborators in the University of Minnesota that helped me to be able to be here, especially Dr. Kelvin Lim, who is already here among the audience, that basically they helped me to do both my psychiatry residency and having a lab at the same time, which is not easy to do, but I'm really thankful for their support. And also my Laureate Institute for Brain Research, Martin Paulus. I'm not sure, probably Martin is not here, but his main support for making the research I'm presenting today. So as we have been discussing today, we have been talking about different neural circuits that are involved in drug addiction, and how we might be able to consider those neural circuits and how we might be able to target them with different sort of non-invasive brain stimulation technologies, whether they are transcranial focused ultrasound, magnetic stimulation, electrical stimulation. And so far, up to end of 2022, we have over 200 published clinical trials using electrical stimulation or magnetic stimulation in drug addiction. And the number is just increasing over time. And people are targeting different areas in the brain, and there is a kind of large variation in terms of what people are doing. And one of the main questions is, okay, how we might be able to improve the quality of research in the field, how we might be able to do optimization. And all the speakers in this panel, we have been discussing about how we might be able to improve neuromodulation, and specifically on drug addiction. And for being able to do that, we have at least 4 levels of optimization. From the context, from the targets, how to optimize the dose, and how to optimize the timing of the intervention. I'm going to discuss about all those 4 dimensions, both in the group level and also in the individual level. So these are going to be different things that we can discuss today about. The first thing that we are going to talk is about basically the context. And starting with the question, which one do you prefer, French fries or a brownie right now? Who likes to have French fries? And who likes to have a brownie? Okay, so it seems that there are more people who are interested to have French fries. So that is the sort of context to put you in a situation that you are going to decide different options that you have. And it's important to mention that those contextual cues right now are a part of what we do for some of the FDA-approved neuromodulatory interventions. I'm not sure, do we have anybody who is doing OCD treatment using the H coils? Do we have anybody here? Okay, so those who are doing OCD research with TMS, they know that one of the things that is a part of the FDA protocol that you need to expose people to those cues. And sometimes we even ask people to bring their own cues or develop some kind of a database of the pictures that provide them with the symptoms of OCD before starting the process. And it's also the case for the FDA approval for nicotine. And we basically, that's a part of the protocol, as you can see here, what we call the provocation administration. And that is the Q exposure part. And how we do it in the lab, this is one of the databases that we have recently developed. 320 methamphetamine and opioid and controlled drug cues to be able to expose people to the environment that is the real context of drug use. And using those kind of drug cues, we can activate different neural circuits in the brain, and there's already a discussion in terms of, okay, what would be the right target among those areas, but we can have something like a brain response to that. And to be able to extend that, right now what we are trying to do, we basically developed a consortium of labs that are doing fMRI drug cue reactivity across the world. And so far, we have been successful in convincing 35 labs to basically share their databases in a large database. And we are hopeful to be able to encourage a few other labs, because we are hopeful to be able to have something like 3,000 patients that they have drug cue reactivity, the fMRI drug cue reactivity data, to be able to go beyond the things that we are doing right now and be able to do more precise targeting using the valid context that would be important. And then the next level would be target. I mean, we have been discussing about the targets. Mark was talking about the targets, Robin, Tanisha. We have been always discussing about what would be the right target. Where can we target? And there is always a discussion in terms of, okay, what are the best targets? I'm interested to basically two major targets that we discussed today as well in terms of what we call, one of the major target is the executive control network, or what we call frontoparietal network, and how we might be able to target frontoparietal network. And the way that I like to kind of target frontoparietal network, one of the ways is what we call frontoparietal synchronization. So we are interested to basically stimulate both frontoparietal side with alternating current, with synchronized alternating current, to be able to basically get them connected and enhance the engagement of frontoparietal network. And the initial assumption that we have in terms of when we have people who are already sober and they are in treatment, when we expose them to drug-related cues, they exert a level of control to be able to control their craving. So we like to have executive control network involved in that process. So if I define something like an areas of frontoparietal network, and conventionally we call it as something like F4, P4, F3, P3, we are hopeful that when we do something like task-based fMRI connectivity between these areas, when we expose people to drug-related cues, we are interested to see these areas are actually connected to each other. And this is not the case. So as you can see, it's quite interesting that kind of F3, F4 would be disengaged when we expose people to drug-related cues, and we are talking about PPI, psychophysiological interaction analysis. So they are pretty disengaged, but there is no interaction between F3 and F3, P3 or F4, P4, which was a little bit kind of surprising for us, and that was not what we have been expecting to see. We have been expecting to have an engagement of that network when we expose people to drug-related cues while they are sober. So we have done another level of analysis in terms of kind of considering the seeds in the frontal areas, and have done a whole brain analysis for PPR to see, do we have any engagement of the kind of a larger network of executive control network? And we realized that, yes, we do have that kind of engagement. We have a parietal node which is getting activated, but this is not the area that, as you can see, this is kind of the presentation over the cortex, and these kind of activation clusters are not in P3, P4. They are in something like CP5, CP6. And this is what we call kind of group level optimization in terms of, okay, it seems that if we want to engage frontoparietal network, we are not going to go for F3, P3, F4, P4, but we are going to go for F3, CP5, F4, CP6. So that is how we inform the optimized montage for electrode placement. And if we do that, as you can see here, then we have engagement of that frontoparietal network that in the process of being exposed to drug-related cues. The other target that we discussed today as well is what we call frontopolar cortex. As Mike beautifully mentioned today, there is a recent lesion-based study that shows that frontopolar cortex could be one of the potential targets. And then I was discussing with a few other colleagues that it seems that we have the same sort of activation in frontopolar area. And Colin Hanlon and I basically put together the database that we had, and we showed, yes, we have sort of similar area while we expose people to drug-related cues in frontopolar cortex. And it seems that they are reasonably matched to each other and across different substances. And even we are right now looking into other databases of cocaine and other kind of and opioids, and they are pretty similar in terms of having that specific location being involved. And I mean, that's the kind of lesion study side, and these are the kind of the map that I showed you before. That is basically the frontopolar area that is engaged and has extensions to the ventromedial prefrontal cortex as well. And if I just show you the cluster that we have been discussing, the frontopolar activations, and define how that frontopolar part is connected to the other parts of the brain in cue-based connectivity analysis, there are two major sites that are involved. One is left amygdala, and the other is DLPFC, with different kind of the positive and negative connectivity while we expose people to drug-related cues. So those two sites are pretty interesting. So I will get back to those sites in a bit in terms of how they are going to be probably interesting and important for us. But discussing about kind of the lesion-based map that Mark presented today, and if we go back to what Colin Hanlon has been doing extensively, and I'm basically calling that point of a stimulation Colin Hanlon's point, because that is what she basically brought up to the field, and she has been doing lots of really interesting research on that side. If we do something like a computational head modeling, that side is actually overlapping. The electric field distribution is overlapping with the lesion map that Mark was presenting. So as you can see, they are beautifully kind of overlapping to each other. So it seems that they are targeting the same area. And then the H coils that Mark presented, I mean, they are also overlapping on the same kind of area. And then it might be interesting that the most kind of replicated area with electrical stimulation that would be able to change the drug-related craving is the montage that we call F3P3, that we put the electrodes over F3 and P3. And people sometimes they say that we are stimulating DLPFC with putting electrodes on F3P3. But in reality, when you do computational head modeling, then you put the electrodes over F3P3, the highest electrical current is in the frontopolar cortex. As you can see here, this is the computational head modeling of F3P3 montages, and they are actually stimulating frontopolar cortex, not DLPFC. And that's another piece of evidence that it seems that they are converging to each other, that we are basically targeting that frontopolar area. And that connectivity between medial prefrontal cortex or frontopolar area to left amygdala is also interesting because of some other previous publications that people tried to see what are the predictors of relapse across different substances. Mainly this one is cocaine, and the work that has been done by Elliot Stein and also others who, I mean, Betty Joy is already here. So those who have been involved in kind of such a nice work. But what they showed that basically left centromedial amygdala and the connections with basically ventromedial prefrontal cortex, which extends to frontopolar area, predicts relapse in cocaine users. So that is another kind of interesting piece of evidence. And when we put the seed on the left medial amygdala, as you can see here, we have a nice cluster in the group level. We have a nice cluster in the ventromedial extending to the frontopolar area. Among this is a database 60 methamphetamine users. So you can see that you have the activations on those areas. So we started to think about, okay, if we want to do an individualized stimulation, how much the targets would be distributed across the frontopolar cortex. And this is something that we have started to do with Ghazaleh, who I will kind of talk about her work in the next slide as well. We tried to see how that basically areas of stimulation or maximum connectivity would be distributed across the frontopolar area. And it's pretty widely distributed. So there are, and these are, each point would be one single patient with methamphetamine use disorder. And you can see there are, within the X, Y, Z axis, they are widely distributed across the frontopolar area. And it might be interesting that individualized frontopolar connectivity would also be related to the level of craving that these people report. So that could be an idea in terms of how we might be able to do personalized intervention. And I will get back to that later in the other pieces of my talk. But the other dimension, so far we discussed about context, we discussed about target. Now let's talk a little bit about dose. How we might be able to need to optimize the level of dose that we deliver. Starting with the frontoparietal network that we have been discussing about. So within the frontoparietal network, if we put the electrodes on F3P3 among 60 patients, meth use disorder, you see that we will have almost the same distribution of electrical currents in frontal and parietal sides. There is a significant inter-individual variation, but the distribution is almost the same in the group level. But if you put the electrodes in the new montage that I introduced, F3CP5, then the parietal side would receive a lower level of electrical current. And if you want to have a balanced level of electrical current, you basically need to change the level of electrical field, the level of electricity that you provide to different nodes to be able to have the same distribution of current. So then you need to optimize your dose in the group level. So that is a dose optimization in the group level. Okay, that is an example of dose optimization in the group level. And then for frontopolar cortex, as we discussed, I mean, that specific target in the frontopolar side and the variations that we had in terms of across different participants, so we can optimize the location. But the next question would be, okay, how we might be able to optimize the orientation of the coil? And how does it matter in terms of the level of electrical current that they receive in the electrical field modeling? And it could, if we optimize the orientation of coil, we can have higher level of electrical current within the targets that we are interested to have. And I mean, this is something that we have recently started to work toward with the robotic arms, trying to see how we can optimize that and optimize the frontopolar stimulation using robotic arms. And that's an ongoing discussion, even ongoing discussion in terms of how to optimize the handle of the coil and other pieces of the coil. I can discuss about that in further details if you are interested. But then the next level would be the amount of energy that we put inside the coil. And if we do not optimize that in the individual level, the level of electrical field that you have in different individual would be totally different. And if you want to have the same level of electrical field in each individual, you need to optimize that as well. So we need to have at least 3 levels of optimization. And if you are interested to know more about that proposed pipeline for individualization, Ghazaleh will have a presentation on Saturday on 5 p.m., right, Ghazaleh? So yeah, she's going to present that, and you will definitely enjoy. So please join us on that side, and we'll discuss about how we have been doing that and how you might be able to use the pipeline that we developed. The last piece of optimization is about the timing. As Tunisia mentioned, in terms of the temporal dimension of the stimulation, how we might be able to optimize in the temporal dimension, okay? One of the things that people realize over time is that, is there any, and this is I'm showing you a few slides from the TMS-EEG works of Alex Opit's lab. And what Alex is doing, looking for the question in terms of when we do the TMS in the motor cortex, and while we are recording EEG, is there any difference if we do the stimulation while we are on the peak of, for example, mu oscillation, or beta oscillation, or when we are in a trough, or when we are going up, or when we are going down? So is there any difference in terms of how motor cortex would respond in different states of oscillation when we deliver electrical current into the motor cortex. And yes, there is a variation in terms of how motor cortex will respond to the stimulation based on the kind of state of activities that we have in the motor cortex. And that's a question in terms of how we might be able to optimize TMS based on the oscillatory rate. And this is what we do in defibrillators, right? I mean, if I just collapse on the stage right now, probably one of the things that you need to do, find one of the defibrillators. And I mean, those defibrillators, how do they work? I mean, I'm not sure if you have one of them here, but then probably, hopefully Mike would be able to kind of use that defibrillator. But one of the first things that, Mike, you are going to do with the defibrillator, what would be just delivering the electrical current, or what is the other step before that?
Before shocking you?
Before shocking me, yeah. CPR, okay. One of the other interesting things that is happening with those kind of defibrillators, they can record your EKG, and based on your EKG, they deliver current, because you cannot deliver the electrical current in any kind of, you cannot deliver it, I think, in the some like PR phase. So if you deliver the electrical current in kind of the wrong kind of piece, it could make problems. So we do that with defibrillator and EKG, so that might be the case for TMS, EEG as well. Recent things that people are doing with TMS, EEG, depression, they have not been that much promising. So we'll see whether it's going to be something interesting in the future or not. But the other level of time-related optimization could be in what we have been discussing about frontoparietal synchronization. Because when we talk about frontoparietal synchronization, we are talking about, okay, we want to synchronize these two nodes. What would be the right frequency that we are going to oscillate in these two nodes to basically kind of synchronize them together? And there is a wide range of different frequencies that you can use. And also, is there any chance that we can have different phase differences between these two nodes? And are we going to have something like 10 degrees of phase difference between these two nodes? Are they going to have 0 phase difference? So that is a temporal dimension that we can optimize. And it's a large parameter space. And the question is how we might be able to find the right target for that. And for each of those points, we need to do something like a clinical trial and just explore, okay, if you go from this phase or that, is it going to work or not? So one of the things that we have recently started to develop is just basically, because right now we can do electrical stimulation inside the scanner. And we have a specific target for frontoparietal synchronization, and we know that, okay, how that should be optimized. And now we are working in terms of how we can make a closed loop in terms of looking into that search space that I showed you before and looking for different phases and different frequencies while we are recording fMRI inside the scanner. And based on the response, we can just find the right spot. And that is the way that we do closed loop TES fMRI. And to be able to do that, we basically developed the initial kind of steps, doing the stimulations on watermelons and all those kind of challenges of how to get into the mesh panel and kind of the penetration panel and how to manage the signal, all those challenges you can imagine. And you can see inside the watermelon. It's just beautiful to see how it is the quality of the watermelon with just the MRI scanning. And of course, after kind of doing the stimulation on the watermelons, we just bring them and just eat them. And that's kind of the fun part of the end of each session that we have with watermelons. And of course, after watermelon stimulation, and we have been able to manage the signal and noise and other things that we had inside the scanner. Our MR physicist team, they have been really skeptical in terms of we can make that happen, but we have been finally, convince everybody that it's technically doable and we can do that inside the scanner. And of course, PI should go inside the scanner after watermelon to test the process. And we have been able to do that inside the scanner. And that is the setting that we have right now in terms of making that happen, to be able to record frontoparietal connectivity inside the scanner, doing the stimulation and optimizing the stimulation frequency on the next round. And we published a checklist of different technical details that you need to do when you do concurrent TES fMRI. And there are many minor items that you need to consider in terms of placement of the electrodes and the kind of the characteristics of the electrode, and also designing the studies and kind of the timing between different stimulation and recording. Those who are interested, we recently published a paper, and we put all those technical details in terms of the online closed loop, real-time TS fMRI in that paper. So you can find the paper and the technical details there. And this is the kind of the protocol that we are testing to see how it works in terms of the optimization of the algorithm. And we have recently done something like a pilot clinical trial with something like 10 participants in each group, and we showed that the technique is technically feasible. So I do not have the final results right now. I probably will show you the results in the next meeting, but at least in terms of the side effects and how people can tolerate that inside the scanner, it's technically feasible. And now there's a large group of people around the world that we made a network of those who are doing electrical stimulation and fMRI together inside the scanner, and now we are working together in terms of how we might be able to do that together. And these are basically my last slide. I'm just going down in terms of the things that we are going to do in the future. And then we realized that, okay, it seemed that we need to expand the network to what we call international network of neuromodulation, neuroimaging, because there are people who are doing neuroimaging, neuromodulation. And we had a workshop in NIH in October last year, and we realized that we need to basically make that international network happen. And now we are shaping sub-networks in the international network of neuroimaging, neuromodulation, to be able to basically help people to do virtual collaborations, increase diversity, global representativeness, increasing the transparency and methodological rigor. And this is the WhatsApp group that we have for the network. If you are interested, you can just scan the QR code and join the network. We will have some discussions in OHPM. We are putting together a kind of a special interest group in OHPM, specifically on neuroimaging, neuromodulation, a study group in ISMRM, and also we are hopeful to be able to put together, we are discussing with Desmond in terms of putting together something like a panel and a study group in ACMP this year. And lots of discussions, webinars that we are organizing. This is something that we had on April, and we have just published the videos on YouTube. And the QR code, you can find the videos on YouTube. So all those webinars right now are available online, and you can follow them. And meanwhile, in the field of electrical stimulation and magnetic stimulation addiction, as I mentioned, there are many studies, and they are distributed around the world. So it is not us in the US leading the field. People around the world are working that. Something like 20% of research in the field are being published in the US. And it's important for us to be able to collaborate with people around the world. So we made a network that we call International Network of TS, TMS Trials in Addiction Medicine, and we worked together. We had another webinar. Mark was there, others. We have been kind of discussing about how to do personalized non-invasive brain stimulation in addiction treatment, and we published a consensus statement, and now we are publishing the new one, hopefully for 2024. Take-home notes. We have a growing body of evidence in the field of addiction using TS-TMS trials. There is a large inter-trial and inter-individual variability in the field right now. We can discuss about group level and individual level optimizations for the context. Do we need to develop individualized context for people, or should we do that in the group level? How we can do that in the kind of optimized way? How can we do target optimization? As Robin mentioned, in terms of how we can do that in a reliable way and a robust way. Is just one single session fMRI for 10, 20 minutes is going to be enough? How we can optimize that to make that happen? How we need to optimize the dose? Do we need to optimize that or not, and how that should be happening? What is the protocol for dose optimization? And then discussing about time optimization and the challenges for time optimization. And I do believe that we definitely need to do work together. So we need to develop those networks. And now, after pandemic, we can just get together in a Zoom kind of meeting room, people from around the world, and try to see how we can work together. And that's the beauty of post-pandemic era. So that is the opportunity that we can work together. My last slide. Have you changed your mind? Anybody who, yeah. So hopefully they are going to feed us during the reception. I'm not sure whether they're going to provide us with French fries or brownie, but yeah, sometimes people change their mind after kind of 30 minutes of spending their glucose. And that is my last slide, just thanking all those who helped me to make that happen, and you have my slides in the QR code. Thank you very much for your attention.